Hello everyone, this is Dr. Sam and this video is about fetal chest ultrasound reporting. You will learn how to write ultrasound reports regarding fetal chest pathologies. The reports will include the findings and the impression. Our first report is of ventricular septal defect. These are the findings: heart position and size, normal cardiac access, heart size within normal limits for gestational age, chambers and valves, all four chambers of the heart visualized, the atrioventricular valves appear normal, ventricular septum, there is evidence of an abnormal opening in the interventricular septum, suggestive of a ventricular septal defect. The defect is located in the mid-muscular portion of the septum. Keep in mind that this is not a complete obstetric ultrasound report. We are just focusing on chest pathologies. Outflow tracts, normal alignment and size of both the aorta and pulmonary artery. Rhythm, regular cardiac rhythm observed during the examination. Other findings, no additional abnormalities noted in the thoracic cavity. The lungs and diaphragm appear normal. This is the impression. Findings consistent with a mid-muscular ventricular septal defect. Recommended follow-up with a pediatric cardiologist for further evaluation and management. The remainder of the fetal chest structures appear normal. It is recommended that the findings be correlated with clinical and laboratory data. This line is important. Further evaluation with fetal echocardiography may be beneficial for a detailed assessment of the cardiac anatomy and function. This is a report of atrioventricular septal defect. These are the findings. Chamber view, abnormal 4-chamber view noted. Both atria and ventricles are of equal size. Atrioventricular valves, there is a common atrioventricular valve instead of separate tricuspid and mitral valves. This valve appears to be regurgitant. Ventricular septum, evidence of a defect in the lower part of the atrial septum and upper part of the ventricular septum, indicative of an atrioventricular septal defect. Atrial septum, the primum atrial septum is deficient. Ventricular outflow tracts, normal alignment, but there may be an associated anomaly. Further evaluation needed. Rhythm and rate, regular cardiac rhythm and normal heart rate for gestational age. No additional abnormalities were noted in the fetal chest. This is the impression. The ultrasound findings are consistent with a complete atrioventricular septal defect. This condition is often associated with chromosomal anomalies, and further genetic testing may be recommended. It is advised to have a detailed fetal echocardiography for a comprehensive evaluation of the cardiac anatomy and function. The findings should be correlated with clinical and laboratory data. Close monitoring and follow-up are essential for managing this condition. Now we have Ebstein's anomaly. These are the findings: heart position and size. The heart is in a normal position. Heart size appears enlarged in proportion to the gestational age. Chambers and valves. Atria, normal size right and left atria. Ventricles, right ventricle appears enlarged. Tricuspid valve, Abnormal tricuspid valve with downward displacement towards the apex of the right ventricle, suggestive of Ebstein's anomaly. The septal leaflet of the tricuspid valve appears dysplastic. Ventricular function, reduced function of the right ventricle observed. Atrial septum, an atrial septal defect is noted, possibly secondary to the altered hemodynamics due to the tricuspid valve anomaly. Regular cardiac rhythm observed during the examination. This is the impression. The findings are consistent with Ebstein's anomaly, characterized by the apical displacement of the septal leaflet of the tricuspid valve and right ventricular enlargement. An associated atrial septal defect is also noted. These findings warrant further evaluation and close monitoring. Consider genetic counseling, as Ebstein's anomaly can be associated with genetic syndromes. These ultrasound findings should be correlated with the clinical context and other diagnostic data. Continuous monitoring and follow-up are recommended due to the potential for progression and the need for intervention postnatally. This is a report of hypoplastic left heart syndrome. Here are the findings. Heart position and size, normal heart axis and position, overall heart size within expected limits for gestational age. The left atrium and left ventricle are severely hypoplastic. The mitral valve appears atretic or severely stenotic. The aortic valve is hypoplastic, leading to a significantly narrowed ascending aorta. The right ventricle is enlarged and appears to be compensating for left ventricular hypoplasia. Septal structures, intact atria and ventricular septa noted. Patent ductus arteriosus observed, which is crucial for systemic circulation given the left heart hypoplasia. Regular cardiac rhythm was observed during the examination. Here is the impression. The ultrasound findings are consistent with hypoplastic left heart syndrome, characterized by severe hypoplasia of the left ventricle, atresia or stenosis of the mitral and aortic valves, and hypoplasia of the ascending aorta. This condition requires immediate attention and intervention after birth. Immediate referral to a pediatric cardiologist is advised for detailed fetal echocardiography and further management planning. These findings should be integrated with clinical and other diagnostic data. Prenatal counseling regarding the prognosis and postnatal intervention options is essential. This is a case of transposition of the great arteries. These are the findings. The heart size is normal. Chambers and valves. Four-chamber view appears normal with appropriate chamber sizes and functioning valves. Arterial arrangement. Abnormal arrangement of the great arteries noted. The aorta rises from the right ventricle and the pulmonary artery rises from the left ventricle, consistent with transposition of the great arteries. Vessel relationship. The great vessels are observed in a parallel course rather than the typical crisscross pattern. This feature is more significant and helps us in diagnosing transposition of the great arteries. Septal structures, intact atrial and ventricular septa, no evidence of septal defects. Ductus arteriosus, patent ductus arteriosus present, which is essential for systemic and pulmonary circulation. cardiac rhythm, regular rhythm and normal heart rate for gestational age. This is the impression. The ultrasound findings are indicative of transposition of the great arteries, a significant congenital cardiac anomaly requiring immediate attention and surgical intervention after birth. Genetic counseling is advised, as TGA can be associated with other anomalies or genetic syndromes. Planning for delivery in a facility equipped to manage high-risk neonates with congenital heart disease is recommended. Regular monitoring and follow-up throughout pregnancy are crucial for management and planning of postnatal care. Now we have a case of Tetralogy of Fallot. Findings: heart size and position normal for gestational age with no evidence of cardiac axis deviation. Chambers: right ventricular hypertrophy observed. Ventricular septal: presence of a large ventricular septal defect, likely perimembranous. Pulmonary artery: pulmonary stenosis noted with narrowing at the pulmonary valve. Aorta: overriding aorta observed, with the aortic valve positioned above the ventricular septal defect and receiving blood from both ventricles. No additional anomalies were found. This is the impression. The ultrasound findings are suggestive of Tetralogy of Fallot, characterized by four key features: right ventricular hypertrophy, pulmonary stenosis, ventricular septal defect, and an overriding aorta. This condition is a complex congenital heart defect requiring comprehensive evaluation and management. Planning for delivery in a facility with neonatal cardiac care capabilities for immediate postnatal management is advised. Continuous monitoring and follow-up are essential. These findings should be correlated with clinical and laboratory data for a comprehensive evaluation. This is a report for double outlet right ventricle. These are the findings: normal cardiac axis, heart size within normal limits, chambers and valves. Four-chamber view appears normal. However, right ventricular dominance is noted. Arterial connections, both the aorta and pulmonary artery, are seen arising predominantly from the right ventricle, indicative of double outlet right ventricle. Vessel relationship: the great vessels are malaligned, with the aorta positioned anteriorly and to the right of the pulmonary artery. Ventricular septum: presence of a VSD, which is often associated with double outlet right ventricle. No additional anomalies were detected. Regular cardiac rhythm observed during the examination. This is the impression. The findings are consistent with double outlet right ventricle, characterized by both great arteries arising from the right ventricle, along with a ventricular septal defect. This condition is a significant congenital heart defect requiring careful postnatal evaluation and likely surgical intervention. Genetic counseling may be considered, as DORV can be associated with chromosomal anomalies. Planning for delivery in a specialized center capable of managing complex congenital heart diseases is recommended. This is a report of Truncus Arteriosus. These are the findings. The heart size and position are normal. Normal four-chamber view. No significant chamber size discrepancy noted. Arterial trunk: a single great artery, the Truncus Arteriosus, arises from the heart. giving rise to the systemic pulmonary and coronary circulations, vessel relationship, absence of separate pulmonary artery and aorta. Ventricular septum, presence of a ventricular septal defect, typically large and perimembranous. No additional anomalies were found. Regular cardiac rhythm observed during the examination. This is the impression. The findings are suggestive of Truncus Arteriosus, a congenital heart defect characterized by a single arterial trunk arising from the heart, a ventricular septal defect, and absence of a separate pulmonary artery and aorta. This condition requires comprehensive evaluation and management, including surgical intervention after birth. These findings need to be correlated with other clinical and diagnostic data. Regular monitoring and follow-up throughout the pregnancy are essential for optimal management of this condition. This is a report of Ectopia Cordis. Here are the findings. Thoracic structure, abnormal thoracic wall development noted. Cardiac positioning, the fetal heart is partially or completely located outside of the thoracic cavity, indicative of Ectopia Cordis. Heart size and morphology, the heart size appears normal. However, detailed assessment of cardiac morphology is limited due to abnormal positioning. The cardiac function appears compromised, likely due to the ectopic positioning. Associated anomalies, possible presence of other structural abnormalities which could not be definitively characterized due to the unusual cardiac position. No additional abnormalities detected in the observed portions of the abdominal cavity and other thoracic structures. Here is the impression. The ultrasound findings are consistent with Ectopia Cordis, a rare congenital defect characterized by abnormal positioning of the heart outside the thoracic cavity. This condition often presents with other congenital anomalies and requires comprehensive evaluation and management. Genetic counseling may be recommended as Ectopia Cordis can be associated with chromosomal anomalies. Continuous monitoring and follow-up are essential due to the complexity and rarity of this condition. This is a case of rhabdomyoma. It is a tumor of the heart muscle. These are the findings. Heart position is normal. Cardiac mass. Location. A well-defined mass is noted in the myocardium of the left ventricle. The mass measures approximately 1.5 centimeters in diameter. Characteristics. The mass is homogeneous and non-invasive in appearance, consistent with a rhabdomyoma. Cardiac function is currently preserved with no evidence of outflow obstruction or significant valvular impairment. No additional anomalies were seen. This is the impression. Findings suggestive of a rhabdomyoma in the left ventricle, measuring approximately 1.5 centimeters in diameter. Rhabdomyomas are the most common cardiac tumor in the fetal population and may be associated with genetic conditions such as tuberous sclerosis. Fetal MRI is advised to assess the impact of the mass on cardiac structure and function. These findings should be integrated with overall clinical context for optimal management. This is a case of congenital diaphragmatic hernia, diaphragmatic integrity, evidence of a defect in the diaphragm, suggestive of a congenital diaphragmatic hernia, herniated contents, abdominal organs including the stomach, loops of bowel, and possibly the liver are observed within the thoracic cavity. Lung development. The ipsilateral lung on the same side of the hernia appears hypoplastic. The contralateral lung appears normal in size. Heart position. The heart is displaced to the opposite side of the hernia, likely due to the presence of abdominal organs in the thoracic cavity. No additional anomalies noted in the visible thoracic structures. Abdominal cavity. Reduced abdominal cavity size, consistent with herniation of organs into the thoracic cavity. This is the impression. The findings are indicative of a congenital diaphragmatic hernia characterized by herniation of abdominal organs into the thoracic cavity through a diaphragmatic defect. This condition has implications for lung development and may affect neonatal respiratory function. Additional imaging such as fetal MRI is recommended to further assess the extent of organ herniation and lung hypoplasia. The severity of CDH can vary, and prognosis is largely dependent on the extent of lung hypoplasia and associated anomalies. These findings should be correlated with clinical and laboratory data for comprehensive management. Now we have a report of congenital pulmonary airway malformation type 1. These are the findings. Lung lesion. Location. A large cystic lesion observed in the right lung. Characteristics. The lesion is characterized by a large cyst consistent with type 1 macrocystic congenital pulmonary airway malformation. The lesion measures approximately 7 mm in its largest dimensions. Lung tissue. Remaining lung tissue appears compressed but otherwise normal. Mediastinal shift. Slight mediastinal shift towards the opposite side, likely secondary to mass effect from the lesion. The heart. Slight displacement towards the opposite side, secondary to the mass effect from the lesion. No additional anomalies were found, and there were no signs of hydrops fetalis at the time of examination. This is the impression. Findings are suggestive of type 1 CPAM in the right lung. This type of CPAM can potentially impact respiratory function depending on its size and growth. The prognosis of CPAM largely depends on the size of the lesion and the presence or absence of hydrops fetalis. Ongoing monitoring is essential to assess for changes in the size of the lesion and potential complications. Referral to a fetal medicine specialist and a pediatric pulmonologist for further evaluation and management is recommended. Now we have a report of type 2 CPAM. These are the findings. Lung lesion. Location. A complex cystic and solid lesion is observed in the left lung. Characteristics. The lesion consists of multiple small cysts intermingled with solid components, indicative of type 2 congenital pulmonary airway malformation. Mediastinal shift. Notable shift of the mediastinum to the right, suggesting significant mass effect from this lesion. Lung tissue. The right lung appears normal. Compression and reduction in size of the left lung tissue adjacent to the lesion. Heart. Cardiac position shifted to the right side. No apparent structural anomalies of the heart. No other thoracic anomalies were detected. This is the impression. The findings are consistent with type 2 CPAM in the left lung, characterized by a mixed cystic and solid lesion. The lesion's size and location have resulted in a mediastinal shift to the right, indicating a significant mass effect. Now we have a report of type 3 CPAM. These are the findings. Location. A large, predominantly solid appearing lesion is noted in the left lung. Characteristics. The lesion is consistent with type 3 CPAM, characterized by a bulky, hyperechoic mass. Size. The lesion occupies a significant portion of the left hemithorax. Mediastinal shift. There is a marked shift of the mediastinum towards the right side, indicating a substantial mass effect. Lung tissue. Compression and hypoplasia of the normal left lung tissue. Right lung appears normal. Displacement of the heart is to the right side. Structural anatomy appears normal. No additional anomalies were found. This is the impression. The ultrasound findings are suggestive of a type 3 CPAM in the left lung, presenting as a large microcystic mass causing significant mediastinal shift. This type of CPAM is less common and can have significant implications for fetal development and postnatal respiratory function. Fetal MRI is recommended to provide a more comprehensive assessment of the lesion and its effects on the thoracic cavity. Urgent referral to a fetal medicine specialist for in-depth evaluation is advised. This is a case of bronchopulmonary sequestration. Lung lesion. Location. A mass is observed within the left lung. Characteristics. The lesion appears as a well-defined echogenic, non-cystic area consistent with bronchopulmonary sequestration. Vascular supply. Abnormal blood supply to the lesion, likely from the systemic circulation, is noted, which is characteristic of BPS. The lesion measures approximately 2 centimeters. Mediastinal shift. There is a marked shift of the mediastinum towards the right side, indicating a substantial mass effect. The heart is normal in size and morphology. No additional anomalies were found. The abdominal cavity was also normal. Lung tissue. Compression and hypoplasia of the normal left lung tissue. Right lung appears normal. Heart. Displacement of the heart to the right side. Structural anatomy appears normal. No other anomalies were found. This is the impression. Findings suggestive of bronchopulmonary sequestration in the left lung. The lesion is characterized by a non-cystic echogenic mass with systemic arterial supply, with significant mediastinal shift to the right side. The prognosis of BPS largely depends on the size of the lesion and the presence of associated complications. Ongoing monitoring and a multidisciplinary approach are essential for management. Now we have Bronchogenic Cyst. These are the findings. Lung lesion. Location. A cystic lesion is identified in the left lung. Characteristics. The lesion appears as a single, well-defined cystic structure consistent with a bronchogenic cyst. The cyst measured approximately 3 centimeters in diameter. There is evidence of a mediastinal shift towards the right, indicative of significant mass effect from the cyst. The heart appears displaced to the right, though cardiac structure and function seem unaffected. No other anomalies were found. This is the impression. The ultrasound findings are suggestive of a bronchogenic cyst in the left lung, measuring approximately 3 centimeters in diameter, accompanied by a notable mediastinal shift to the right. This condition is a congenital anomaly, typically arising from the bronchial tree. Fetal MRI is advised to better delineate the cyst and assess its effect on surrounding structures. The presence of mediastinal shift increases the importance of monitoring for potential complications. The size and impact of the bronchogenic cyst will guide management decisions and postnatal care planning. Now we move on to congenital high airway obstruction syndrome. These are the findings. Airway, evidence of high airway obstruction suggestive of congenital high airway obstruction syndrome. Lung morphology, marked enlargement and echogenicity of both lungs, consistent with air trapping secondary to the obstruction. Diaphragmatic appearance, flattened or inverted diaphragm, indicative of increased intrathoracic pressure. The heart appears compressed and centrally positioned due to the enlarged lungs. Polyhydramnios is present, which is often associated with chaos. No signs of fetal hydrops observed at this stage of examination. Here is the impression. The ultrasound findings are highly suggestive of chaos, characterized by obstruction of the fetal airway, leading to enlarged and echogenic lungs, flattened diaphragm, and polyhydramnios. Fetal MRI is recommended to confirm the diagnosis and evaluate the extent of airway obstruction. Multidisciplinary care involving neonatologists, pediatric surgeons, and other specialists is essential. Now we have a case of pleural effusion. Findings: bilateral pleural effusions are observed, with fluid accumulation noted in both left and right pleural cavities. The lungs are compressed due to the presence of the effusions. The cardiac structure appears normal, but the heart is centrally displaced due to the effusions. No evidence of diaphragmatic hernia or inversion. No other abnormalities were found. This is the impression. Ultrasound findings are suggestive of bilateral pleural effusions characterized by the accumulation of fluid in both pleural cavities. This condition can be associated with several underlying causes, including chromosomal abnormalities, infection, or cardiovascular anomalies. Continuous monitoring and a multidisciplinary approach are essential for optimal outcome planning. Now we have a case of pericardial effusion. These are the findings. A significant accumulation of fluid is noted in the pericardial space surrounding the heart. The cardiac chambers and valves appear normal, with no evidence of intrinsic heart disease. Cardiac function: normal cardiac function observed despite the presence of the effusion. There were no signs of fetal hydrops or other abnormalities. This is the impression. The ultrasound findings are indicative of a pericardial effusion. While the heart structure and function appear normal, the presence of the effusion warrants further investigation to determine the underlying cause. which could range from infectious, chromosomal to cardiovascular anomalies. Continuous monitoring and a multidisciplinary approach are crucial for managing this condition. Thank you so much for watching. Please subscribe and stay tuned for more imaging videos.